mute my microphone.
Hello, everybody. In this video lecture, we will cover respiratory system. Okay, so let's go ahead and begin. So respiration involves both respiratory and circulatory system. And what respiration does, it supplies your body with oxygen and disposes carbon dioxide. It includes 4 processes, right? So it says respiration includes 4 processes and involves both respiratory and circulatory systems, right? So here's this 4 processes, right? Pulmonary ventilation, or what we call breathing. So it's a movement of air into and out of the lungs. So this is kind of like easy to understand, right? We have ventilation, air moves in, inhalation, air moves out, exhalation, right? And then we have external respiration. External respiration, oxygen and carbon dioxide exchange between the lungs and the blood. And these 2 functions are functions of the respiratory system. Another process is transport of oxygen and carbon dioxide in the blood. And last one, internal respiration, oxygen and carbon dioxide exchange between systemic blood vessels and tissue. And this is the job of the circulatory system. So when you see this word respiration, like external respiration or internal respiration, that means we will talk about oxygen and carbon dioxide moving between blood, right, and something else. So if it's external respiration, it's between blood and lungs. If it's internal respiration, between blood and tissues, right? But respiration means movement of oxygen and carbon dioxide. Okay, so mechanics of breathing. Well, here it just says that a pulmonary ventilation, right? And I'm going back. This is the first step. Pulmonary ventilation or breathing includes inspiration, gases flow into the lungs, and expiration, gases exit the lungs. So that's pretty straightforward. Now, before we start talking about why actually air moves inside the lungs and why air moves out of the lungs, right? Because we need to look at physiology of the process. We gave a definition, right? Gases flow into the lungs, gases exit the lungs. Now our question is why? Why those gases are moving, right? And before start talking about it, we need to discuss couple terms. The first one is atmospheric pressure. Atmospheric pressure, and abbreviation is PATM. It's a pressure exerted by the air surrounding the body, right? So that's a pressure of air on your body. So when you sitting right now listening this lecture, you actually experience this atmospheric pressure. And because we're so adapted to it, we don't feel it at all, right? But it is the pressure, and it's equal 760 millimeters mercury at sea level. So we move at high elevation and this pressure decreases a little bit. When you go below sea level, this pressure goes up, right? But at sea level, that's the number, 760. So that's a regular atmospheric pressure. Now we have respiratory pressure, and it's always is described relative to atmospheric pressure. So we have, if we say it's a negative respiratory pressure, it means it's less than atmospheric. If it's positive respiratory pressure, it's greater than atmospheric pressure. And zero respiratory pressure, it's not actually zero, it's just equal to atmospheric pressure, right? So that's, keep in mind. Okay, now what type of pressure exists within our lungs? We have 2 types of pressure. we have, I like this intra-alveolar pressure because it tells you it's inside alveoli. Intra means inside, alveoli are those sacs where gas exchange happen, but more common is intrapulmonary, right? So we do need to remember this intrapulmonary pressure. This is the pressure in the alveoli. Abbreviation is PUL, P pulmonary. And sometimes they even call it pulmonary pressure instead of intrapulmonary. So pulmonary pressure inside the alveoli, and it's fluctuate with breathing, and it's always eventually equalize the atmospheric pressure. Why? Because your lungs, right, considered to be open body cavities, right? So let's, for example, if you like open your oral cavity, right, you open your mouth, you have this open cavity, right, that go to your trachea, bronchi, bronchioles, right, and finally to alveoli. And because it's open body cavity, so eventually atmospheric pressure and pulmonary pressure equalizes, right? And another pressure that exists, intrapleural pressure, and abbreviation is PIP, intrapleural, and this is pressure in the pleural cavity. I'm going to show you on the next slide. And this also fluctuates with breathing, and it's always a negative pressure. So it's always less than atmospheric pressure, and as a result, it's always less than pulmonary pressure, right? Because pulmonary pressure always equalize, right, with the atmospheric pressure. Then intrapleural pressure will be, if it's negative, means it's less than pulmonary and atmospheric. Okay, so over here you can see a diagram of the lungs, right? So we have this airway, like trachea, primary bronchi, and all these bronchioles, right? So here inside alveoli, we will have pulmonary pressure or intrapulmonary or even intraalveolar, right, pressure. And between the pleura, you guys hopefully remember from anatomy that pleura is a serous membrane that cover closed body cavity, because even your lungs are open to the atmosphere. This pleural cavity is closed body cavity. And we have two types of pleura. We have parietal pleura that cover your rib cage, and visceral pleura that cover the lungs. And between this parietal pleura and visceral pleura, we have pleural space, a pleural cavity, and that's the pressure measured inside this cavity called intrapleural pressure, right? And it's 756, right? And because our normal is 760, right, over here, this one is less, 756, so it's 4 millimeters mercury less, so we call it negative pressure, right? So that makes sense, right? So we have pulmonary pressure that is 760 millimeter mercury or 0, right? Because it's equal to atmospheric pressure. And we have intrapleural pressure that -4 millimeters mercury, right? So it's a negative pressure. Now, in between, if you take 760 minus 756, you will have what we call transpulmonary pressure, right? So difference between these two pressure, and it gives you a difference of 4 millimeters mercury, right? So now if our intrapleural pressure and pulmonary pressure equals, then lungs collapse. So we must have this transpulmonary pressure, because think about it, if pressure is less over here, it kind of expand your lungs, right? So your lungs expand. It's like you create this force that stretches your lung and keep them open. So the pleural pressure, right, and pulmonary pressure and intrapleural pressure, right? They cannot be equal. If they equal, then lungs collapse, right? So when we find this transpulmonary pressure, we take pulmonary minus interpleural, give us 4 millimeters mercury. This what keeps airway open. The greater the transpulmonary pressure, the larger the lungs, right? That makes sense? Okay. Now, atelectasis is this lung collapse. So lungs can collapse because of several reasons. For example, if we have plugged bronchioles, then it will be collapse of alveoli, or there is some air that admits into pleural cavity, pneumothorax, right? And when air admits in the pleural cavity, if you go over here, if here we have air, then what our pressure gonna be equal to atmospheric pressure. Then we would have 760 here, 760 here, right? And then lungs collapse. And this, you can see on this picture, this right lung, right? That is way small over here. So that's the collapse of this lung. So that's called atelectasis. Okay, so over here we will talk about pulmonary ventilation finally, right? So I just want to remind you what we're talking about. So we said that respiration includes these 4 processes, and the first one is pulmonary ventilation. And we said that pulmonary ventilation consists of inspiration, expiration, and we discussed all this different pressure, right? Before we start talking about how exactly air enters and leaves your lungs, right? So we're still on the very first step of respiration. So pulmonary ventilation is inspiration and expiration, mechanical processes that depends on volume changes in the thoracic cavity. Now, remember I told you we're gonna discuss why air flows inside the lungs and why air flows out the lungs. It happened because of the volume change. So when your thoracic cavity changes the volume, it changes pressure. And when we change pressure, air will flow or move from high pressure to low pressure, right? It's like in a chemistry and biochemistry, right? When we're talking about diffusion, when we talk about even osmosis, right before. So the substances move from high concentration to low concentration. Well, gases move from high pressure to low pressure, right? Because they have this pressure gradient, right? So makes sense. So inspiration and expiration happens because your thoracic cavity changes volume. When volume changes, pressure changes, and then gases flow from high pressure to low pressure, right, to equalize it, right? Okay, so that makes sense. Now, what is the relationship? So we just said when volume changes, pressure changes, but is it, what is the relationship, right? Is it directly proportional or inversely proportional? What Boyle's law tells us, it's inversely proportional. And if you look at this diagram over here, so imagine you have a container and this container has volume 1 liter, right? And you have a certain amount of gas over here. So these molecules of gas express some pressure on the walls of this container, right? And we can see the pressure here is 100 millimeter mercury. Now, what's gonna happen if you change the volume of the container without changing the volume of gas, right? So you actually change, volume gets smaller. Now it's 0.5 liters and pressure goes up, right? Because now kind of you have the same amount of molecules in a smaller space, right? And obviously you will have higher pressure. So Boyle's law just tells us that pressure is inversely proportional to the volume. Volume get bigger, pressure goes, pressure decreases, right? Pressure increases, volume decreases, right? So like they like opposite of each other. Okay, so now we pretty much, okay, so we said that air moves in and out because volume changes, volume of thoracic cavity changes, pressure changes, right? And air flies from high pressure to low pressure. And we also know when volume gets larger, right, pressure gets smaller, right? Volume increase, pressure decrease. Volume decrease, pressure increase, right? Because they are inversely proportional. Okay, now we can really understand the process of inspiration. So let's look, I actually want to go back over here and okay, so you see if I can draw here. No, I cannot. Like if I have a, maybe now I can. Okay, so so imagine those your lungs at rest, right? Now this is diaphragm. Now this diaphragm is relaxed. Now what's gonna happen if you contract the diaphragm? Because diaphragm is a muscle. So if you measure, why my pen is not working here. That's really strange. I don't know why. I'm trying to, maybe I need to, hold on, let me see if I can find a draw. Okay. Pause, annotate. Oh, maybe this one. Yeah, okay. All right, I got it. It's, you know. No. Okay, draw. No, why my pen doesn't work. Maybe it's, oh. Sorry for that. Well, I can use this, I guess. Yeah, oh, well, okay, I have to, I cannot use my pen, so. That's crazy. Okay. So anyways, this is diaphragm, right? So for example, if you measure how long this muscle is, right? So right now, that's what it is, right? This is how long it is, right? So this is how long it is. So let's imagine it's like 30 centimeters, right? Okay, let's say 30 centimeters. Oh. Okay, so 30 centimeters. Now, what's gonna happen when muscles contract? Well, with this muscle contract, it's gonna get shorter, right? So when it gets shorter, that's how it's gonna look, right? So now it's a straight line. So it's a short diaphragm contract, right? So diaphragm get smaller, but look what's happened with my volume. So here's was my first volume from, right? So that's the first volume, right? Over here. And now, let me see where I can pick up a different color. Okay. And now what what my volume now is, right? From here all the way to here. That makes sense? So the point I'm trying to make over here, when diaphragm contracts, the volume of the thoracic cavity increases, right? That makes sense, right? So diaphragm contract, the volume of the thoracic cavity increases, right? So that's what it says over here, right? So, okay. Yeah, I didn't expect this. Remove stuff. Okay, mouse. Okay, so that's what it says. When the respiratory muscles contract, right? And what we mean here mostly diaphragm, right? So let's think about diaphragm right now. When diaphragm contract, chest volume increases. Remember, when volume goes up, what's gonna happen with the pressure? Pulmonary pressure decreases, right? When pressure decreases, then it's now less than atmospheric pressure. So air from atmosphere, from the air, or air from air. So air from outside flows into the lungs until the pressure in the lungs become atmospheric, right? So inspiration is active process. So respiratory muscles contract, chest volume increases, pulmonary pressure decreases. Now we have pulmonary pressure that is less than atmospheric pressure. So air flows from atmosphere inside the lungs and alveoli, right? So it's called negative pressure breathing, right? So it says intrapulmonary or pulmonary pressure drops to -1 millimeter of mercury. That means it's 1 millimeter less than atmospheric pressure, right? So over here, you can actually see more details, right? So, but it tells you exactly the same, right? So you can take a look over here, but this just repeat what we just discussed. Now, what about expiration? Well, quiet expiration is a passive process. So inspiration is active, expiration is passive. Why? Because now respiratory muscle relaxed. Respiratory muscle relaxed, volume of your thoracic cavity or chest volume decreases. Remember, volume decreases, pressure increases. So pulmonary pressure increases. So now pressure inside alveoli are higher than atmospheric, so air will flow out of the lungs until the pressure becomes atmospheric, right? So that makes sense. But when we talk about quiet expiration, but when you have forced expiration, then it's active process as well, and it will use abdominal muscles and internal intercostal muscles, right? Okay, because we cannot use diaphragm. Remember, we only use diaphragm for inspiration. Remember from 50A, what one muscles do, and other muscles need to undo. The same muscles cannot flex and extend, for example, right? So diaphragm itself cannot increase chest volume and decrease chest volume, right? That's why here for expiration, if it's forced expiration, we use abdominal and internal intercostal muscles. Okay, and this is a diagram that describe process of expiration. Okay, good. So next, what are the physical factors that influence pulmonary ventilation? So we're still on the very first stage of breathing. So inspiratory muscles consume energy to overcome three factors that hinder air passage and pulmonary ventilation. So your muscles contract, right? Your respiratory muscles, including your diaphragm and external intercostal muscles, they need to overcome airway resistance, alveolar surface tension, and lung compliance, right? So those are factors that influence your pulmonary ventilation. So let's look at each of these factors. So airway resistance, it's a friction in the major non-elastic, friction is the major non-elastic source of resistance, right? So you have friction in, in your trachea, in bronchi, bronchioles, alveolar ducts, right? So you have all this friction, and this is the main source of resistance. So resistance disappears at a terminal bronchioles where diffusion drives gas movement. So on this graph, you can see that so when airway became larger, right? So let's say this is your, oh, it became smaller, I'm sorry. So for example, that's your trachea, right? So here's the resistance in the trachea. Then from trachea, you go to primary bronchi, right? So they became smaller. So we have more friction, more resistance. So resistance increases until we get to the point when we have so many branches that actually friction decreases, right? It's like you have highway, and then your highway divided into two roads, right? So you kind of have more traffic or you have kind of less traffic. If it's a huge freeway, when then it became like a narrow, you have more traffic jam. But then when your freeway just branches into, let's say, 15 different roads, you know, cars just go different roads, so traffic decreases. The same over here. So first, okay, so yeah, I'm sorry, I don't know, I need to check what's wrong with my pen. It's hard for me to draw, but it does make sense, right? So we have let's say a trachea. Trachea is a pipe that is, you know, has the largest diameter, right? So, and then trachea branches into two primary bronchi, right? So over here. And you would say, okay, so where do I have more friction? Obviously, you have more friction over here because those are passages with a smaller diameter. So less friction here, more friction here. So this is where it goes, right? But then when we get to the point when we have too many different branches, right, then the friction actually decreases, it goes down, and it disappears in the terminal bronchioles, right? So, okay, next, okay, yeah. Why, really? For some reason, I'm stuck over here. Just let me just erase it. Okay, so I get back to the mouse. Maybe I need to this. Oh, I cannot move anywhere. Oh, I need to stop share for a second, then share again. Hopefully this will work this time. Yes, no, that's ridiculous. I am so sorry. I don't know what I did wrong, but now I am stuck on the same slide. And, okay, here, I think I fixed it. Sorry for that. Okay, right, so anyway, this is airway resistance. So why are we talking about it? Because we're talking about pulmonary ventilation, right? And we said, okay, so now what are the factors that affect pulmonary ventilation? Airway resistance. And we know how it affects it. So first resistance increases and then it decreases and it disappears in the terminal bronchiole, almost get to zero, right? As airway resistance rises, breathing movement become more stenosis, severely constriction or obstruction of bronchioles can increase this stenotic breathing. It can prevent life-sustaining ventilation, can occur during acute asthma attack and stop ventilation. And then we can use epinephrine because epinephrine dilates bronchioles and reduces air resistance. Okay, so another factor that affects ventilation is alveolar surface tension. So what is that? So what surface tension is a force that attracts liquid molecules to one another at a gas-liquid interface. And it resists any force that tends to increase the surface area of the liquid. So what it means, so you see this is, this circle represent alveolar membrane. And you do have fluid over there, right? Because, you know, alveolar membrane is made of cells. Cells must be surrounded by some fluids, right? So you have a water molecule. So between these water molecules, you have surface tension. So they are attracted to each other, right? So this molecule attracted to this molecule to this molecule. And because they all attracted to each other, right? Then they kind of tend to pull your alveolus inwards, right? So the forces go inside and it can actually collapse your alveoli, right? So, and now if you want to extend this alveoli, this force will resist. So surface tension surface tension tends to collapse alveoli, right? That makes sense because it's a force, attraction force between water molecules in a liquid gas interface. So we have gas over here and we have liquid covering the alveolar membrane cells. Now, how your body deal with it? Well, your body, fortunately, your alveoli, they have a special cells. It's called type 2 alveolar cells, and they secrete detergent like lipid and protein complex, right? That is called surfactant, right? So alveolar 1 cells, they make the walls of alveoli. All alveolar 2 cells, they secrete this surfactant. And this surfactant reduce surface tension, right? So if you see over here, this is alveolus without surfactant. And over here, when we have this lipid protein complex, it reduces the force. So now the force is shown with the dotted line, right? So it reduces the tension and it keeps alveoli open, right? So insufficient quantity in premature infants, insufficient quantity of surfactant in premature infants causes infant respiratory distress syndrome. Right, so actually respiratory system is one of the last system to develop during embryonic development. So it only develops at the when the fetus is already like 7 to 8 months old, 7 months old, right? Between 7 and 8. This is where respiratory systems start developing, fully. So if somebody born premature, that means these alveolar 2 cells do not produce this surfactant in a needed amount, right? So that can cause collapse of alveoli, right? So, and another factor that affect ventilation is lung compliance. So lung compliance is a measure how your lung volume changes when you apply a force. So it's actually ability for your lungs to stretch and return back to normal volume. So stretch and recoil, stretch and recoil. And of course you can say this would be because of what? Because of some elastic tissue, all right, and in your lungs. So for example, over here, you're giving normal lung compliance. So when you increase pressure, right, this is the volume of the lungs, that's a normal volume of the lungs, so also increases. But when your lungs became fibrotic, so they're losing elastic tissue and get a lot of fibrous tissue, then even you increase the pressure, you cannot stretch the lungs as good as normal lungs, right? But remember, compliance is not only how well you stretch it, but it's also how well it recoils back. So emphysema, for example, you can stretch it, but emphysema is loss of elastic fibers, right? So here you have a lot of fibrous protein, right? And here you're losing elastic fiber. So emphysema, you can stretch it easy, but it doesn't recoil back as fast as a normal tissue, right? So this lung compliance tells you that your lungs need to be healthy. So it needs to be perfect amount of connective tissue, right? Elastic tissue, so they can stretch and recoil back, right? So so lung compliance diminished by non-elastic scar tissue like fibrosis, reduced production or surfactant, right? Then it will be hard to stretch them, and decreased flexibility of the thoracic cage. This can happen with age, right? Okay. So just to kind of sum up this first part of the lecture. So we're talking about respiration, and we said respiration includes 4 processes. The first one, pulmonary ventilation, that include inhalation and exhalation. right? And we just discussed why air moves in and out, because actually inhalation is active process, right? Diaphragm contracts, volume increases, pressure decreases, air moves in, and exhalation is passive process, diaphragm relax, volume of thoracic cage decreases, pressure increases, pressure moves out, right? I know it might be a little bit confusing, but you need to, of course, read it several times again to understand it. And then we said, okay, that's good, but what factor influences this ventilation? Well, there are three factors that influence this ventilation: airway resistance, alveolar surface tension, and lung compliance, right? So that's what we discuss over here, right? Now, so we can obviously perform some pulmonary function test to measure the pulmonary function. Instrument that is used is spirometer, and it's measure volumes and capacity, and it's allow us to distinguish between different pathologies or diseases of pulmonary system, including obstructive and restrictive disorders, right? So pulmonary diseases are divided in these two groups, obstructive and restrictive. So obstructive, when you have problem with airways, with airway resistance. For example, will be bronchitis. So that would be problem in bronchioles, primary, secondary, tertiary bronchioles, right? In a these tubes that leads to your lungs, that will be obstructive. Restrictive disorder are related to your lung tissue itself, right? So that would be, for example, your lungs lose the elastic tissue, became fibrotic after tuberculosis, then it will be restrictive disorder, right? Okay, so that's two different disorders of the pulmonary function, right? Okay, next. So this is what can be measured. We can measure this alveolar ventilation. Alveolar ventilation rate, it's a flow of gases into and out of alveoli during a particular time, right? So alveolar ventilation rate equals frequency of breathing multiplied by amount of air, right, that enters the alveoli. So it's a tidal volume minus dead space, and we will discuss it in a minute. But just again, because we are talking about pulmonary ventilation, right? So we're talking about this very first process of breathing, right? Because we're talking about pulmonary ventilation here. We just said that we can measure pulmonary ventilation, right? We can use a spirometer to measure pulmonary ventilation, and we can calculate alveolar ventilation rate. And this is flow of gases into and out of alveoli during a particular time. And here's the formula, how it's calculated, right? Okay. Okay, next, next step, we have a respiration, right? So that was ventilation. Now we have respiration. And we have two types of respiration. We have external respiration and internal respiration. In between them, we have transport of gases, right? But when we see this respiration, means we're gonna talk about oxygen and carbon dioxide moving from blood to the lungs or to the tissues, and and carbon dioxide also moving from the, okay, so carbon dioxide moving from blood to the lungs, and oxygen moving from blood to the tissues. All right, so yeah, I mean, look, don't want to confuse you a lot, but this is our external respiration and this is internal respiration. External respiration happens in the lungs. Internal respiration happens at the organ and tissue level, right? And you know what your tissue needs oxygen. So oxygen will move from blood to the tissue. Your tissue will release carbon dioxide. So carbon dioxide from tissue to blood. In lungs, it's vice versa, right? Carbon dioxide from blood to the lungs and oxygen from lungs to the blood, right? That's our external and internal respiration, and between them is transport, as I already told you. Okay, I need to speed up a little bit because already almost hour. Okay, so external internal respiration. And again, before we discuss this, we need to be familiar with some processes like physical properties of gases and composition of alveolar gas. Okay, so the first, we use this Dalton's law of partial pressure that tells you that total pressure of a mixture of gas is the sum of the pressure exerted by each gas, right? So like if you have air, what is the partial pressure of air, or total pressure, sorry, total pressure of air? It equals pressure of all the gases that make an air, because air has like oxygen, nitrogen, argon, water, carbon dioxide, right? So you take a partial pressure of all these gases that make this mix, you add them, and it's going to be your total pressure. That makes sense? And partial pressure is directly proportional to the percentage of this gas in the mixture. So more oxygen we have, the higher is the partial pressure of oxygen. So it's not the same, but we can kind of associate partial pressure with concentration, right? We just, when we're talking about air, we don't talk, we don't say like concentration of oxygen in the air is like this and that, right? We don't say it. We say partial pressure of oxygen. But because it's directly proportional to the concentration, right? So it makes sense to kind of think about it as a concentration of the gases that make this mixture, right? It will make sense, right? And another thing is that we need to understand, then when a mixture of gases is in contact with liquid, each gas will dissolve in the liquid in a proportion to its partial pressure. So if you have high partial pressure, then more gas will dissolve. And also the amount of gas that will dissolve in a liquid depends on its solubility. So the amount of gas dissolved in a liquid depends on its partial pressure or its concentration, right? We're not supposed to say it, but it's concentration. And its solubility, how well it's dissolved. Like carbon dioxide, for example, 20 times more soluble in water than oxygen. And very little nitrogen dissolves in water. That's, we have like 78% nitrogen, I think, in the air, and very little actually enters our blood because it's very, very little of it dissolves in the water. Okay, so that's, okay, let me see. So that makes sense, right? So we're talking about external and internal respiration, and we know that when we say air, right, air has oxygen, carbon dioxide, and if we want to describe how much oxygen and carbon dioxide is in this air, we use term partial pressure of oxygen, partial pressure of carbon dioxide. And we also need to know that the higher the partial pressure, higher the solubility, the more of this gas will dissolve in liquid, and it means in the plasma of the blood, right? Now, respiratory volumes. This is very interesting. So let's look over here. So, so respiratory volumes, you know, are very important in understanding of how lungs work, right? And also in some disorders and diseases of the respiratory system. So let's look over here. I like this diagram. It explains a lot. So the first volumes that you need to know is a tidal volume. So tidal volume is amount of air entering and exiting your lungs during a normal breathing, right? And it's about 500 milliliters. So it's a half of the liter, right? So And it's called tidal because tide is, if you go to ocean and let's say it has a tide. So tide means water moves out and in to the shore and out, right? That's a tide. So that's why they call it tidal volume, because that's how you're breathing. In, out, in, out, in, out. So that's your tidal volume. So it's about half of the liters, or 500 milliliters, right? Now, you also can make a very big inhale, right? You can inhale obviously more than tidal volume, right? So you do like, you take as much air as you can in your lungs, and it will be your inspiratory reserve volume. So the maximum amount of air you can force inside your lungs, it's your inspiration, right? So it's inspiratory reserve volume. Now, the same thing is about you exhale 500 milliliters, but you can exhale more, right? You can exhale. So if you just exhale as much air as you can from your lungs, it will be your expiratory reserve volume. But even if you exhale all the air that you can, it still will be some air left in your lung, right? And it's called residual volume. Residuum comes from the same root as resident. Resident, residual. So that's the volume that lives in your lungs, that never, that's always there, even with your very forced, the maximum force expiration, right? Makes sense? So you have, so here you have your 1, 2, 3, 4 volumes. You have tidal volume, normal breathing. You have inspiratory reserve volume. Inhale as much as you can. That will be your inspiratory reserve volume. Exhale as much as you can. This will be your expiratory reserve volume, and something stay inside your alveoli residual volume, right? Okay, now capacities, when we start adding all these volumes. So the first easy to understand is total lung capacity. You just add all of these volumes and you get total lung capacity. Now, when you add everything except of residual volume, it will be your vital capacity. So that's what's allow you to survive. This is as much air that can you can inhale and exhale, right? When you, let's say, running for your life or you exercising, right? That's your vital capacity. And because you cannot really touch residual volume, right? And you have your inspiratory capacity. So you add inspiratory reserve and tidal volume, and you have your functional residual capacity when you add expiratory reserve and residual, right? So that's different volumes and capacities that used to describe how your lungs works, right? Do you have any disorder? Do you have any disease, right? So that's right here. Now, another term is dead space. So some inspired air never contributes to gas exchange. So for example, air, you inhale some air, right? But you have air in your trachea, you have air in your bronchi, in your bronchiole. This air, oxygen and carbon dioxide, is not moving. This air just there in your passages, but it does not involve in an oxygen and carbon dioxide exchange, right? And this is our dead space. So we have anatomical dead space. And this is what I just told you. This is the volume in your conducting zone, in your trachea, bronchioles, right? Bronchi, bronchioles, that's anatomical dead space. And we can have also alveolar dead space. And this is when some alveoli cease to act in gas exchange due to collapse or obstruction, right? And total dead space will be a sum of anatomical dead space and alveolar dead space, right? So dead space is the air, amount of air, volume of air that never contributes to gas exchange, right? Okay, So we doing how we doing so far? Hopefully fine. So we're talking about respiration, external and internal respiration, and we kind of have an understanding what is partial pressure of the gases. We know different volume and capacities of the lungs. We know what that space is. Now let's look at actual respiration, external and internal respiration. Right, so this is the composition of alveolar gas. Of course, you don't need to memorize any of these numbers, but you do need to memorize this pink stuff and this pink stuff, right? So these two numbers you need to know. But this one equals what you have in alveoli. So in alveoli, a partial pressure of oxygen is 100 millimeters mercury, and partial pressure of carbon dioxide is 40 millimeters mercury, right? So remember, this is kind of like a concentration. Now from alveoli, right, your oxygenated blood, well, from alveoli, oxygen, I'm sorry. From alveoli, oxygen moves to the blood and make it oxygenated. So in the left heart, right, from in the pulmonary circulation, right, so from lungs, we move to the left atrium, right, so in the left, and then left ventricle. So in the left heart, we will have the same. Oxygen 100, carbon dioxide 40, right? Pulmonary, I'm sorry, partial pressure of oxygen and partial pressure of carbon dioxide, right? So in the left heart, we have 140, and the same you have in our arteries, large arteries. So that's the blood that your body delivered to the tissues, 140. Now the blood that returns back to alveoli in the right heart will be 40 partial pressure of oxygen and 45 partial pressure of carbon dioxide. So you can see we have a drop in oxygen. So where all this oxygen goes to the tissue. And we have increase in carbon dioxide because this carbon dioxide comes from the tissue, right? So from 40 to 45, right? And it returns to alveoli and you exhale. Okay, so external respiration. So finally we get right to this. After we had some idea of all the terminology, partial pressure, capacities, volume of the lungs, right? After we looked at the composition of the air, now we're discussing external respiration. And again, respiration is exchange of oxygen and carbon dioxide across respiratory membrane. So this happens in the lungs, external respiration. So it's influenced by partial pressure gradients and gas solubilities, ventilation-perfusion coupling, and structural characteristic of the respiratory membrane. So why oxygen moves from alveoli to the blood? Why? Right, because look, I don't know, maybe the next one is good. Okay, yeah, here's will be the picture. So we will get to it, right? So, let's discuss this first. So external respiration, oxygen and carbon dioxide exchange happens between blood and alveoli, right? So why oxygen and carbon dioxide are actually moving? So let's look at this picture that explains stuff. So here's our alveoli, right? So here's the blood from the, let's call it right heart, right? But it's right ventricle. So this is the oxygenated blood. So what is the composition? 40, 45, right? So this is the blood moving up to the lungs, to the alveoli. So we have 45 here, pressure of carbon dioxide, right? And what we have inside alveoli? Inside the alveoli, right? Here, alveoli of the lungs, we have 40. So inside this alveoli, the pressure is 40 of carbon dioxide. Inside this blood, the pressure is 45, right? Now what? What's gonna happen? The carbon dioxide gonna move from higher pressure to low pressure, from blood to the alveoli, right? Not that steep gradient, but because carbon dioxide is very soluble, that works just perfectly. Now, why oxygen from alveoli moves inside the blood? Because this is the blood, right? So this blood over here, pressure of oxygen is 40, right? So here in this capillaries, the partial pressure of oxygen is 40. In alveoli, partial pressure of oxygen is 100. So obviously it's moved from 100 to 40. And when it's moved, it's that blood that's returning back to the heart. Now we have our 140 partial pressure, 100 for oxygen and 40 for carbon dioxide, right? So air moves, always move because of the differences in pressure, right? So now how we make those differences in pressure for ventilation, we increase and decrease of volume of thoracic cavity. For this respiration, external respiration, the carbon dioxide and oxygen moves because of the difference in a partial pressure of oxygen and carbon dioxide, right? Because your air, right, reach in a, well, have a higher pressure of oxygen and low pressure of carbon dioxide. That makes sense. That's why air moves. So that's why we have this exchange of oxygen and carbon dioxide across respiratory membrane, but of course it's influenced by many factors. 3 of them are partial pressure gradient, ventilation-perfusion coupling, and structural characteristic of the respiratory membrane. So partial pressure gradient, we just described it, right? So partial pressure gradient for oxygen in the lungs is very steep, right? Venous blood, we have 40, and in alveoli, we have 100. So where air will move from 100 to 40, from alveoli to the venous blood, right? So here it is. That's a partial pressure for oxygen. Partial pressure for carbon dioxide is less steep because we have venous blood 45 and alveolar pressure 40, but still we have higher pressure gradient. So carbon dioxide will move from blood to the alveoli, and this is what we need so we can exhale it, right? And this I already described. Next factor that affects respiration is ventilation-perfusion coupling. What this means? Look, it means, well, first, ventilation is amount of gas reaching alveoli, and perfusion is blood flow reaching the alveoli. So in the alveoli, we have amount of gas reaching alveoli, that's called ventilation, and amount of blood reaching alveoli, that's called perfusion. And they must match. We call it ventilation-perfusion coupling. So we have efficient gas exchange. So let's look over here, right? And then you can read those slides. So over here we have mismatch, and here we have mismatch. Why? Because here ventilation, look, this is a ventilation, so how big this alveolus is, and here's the ventilation. Here's the ventilation, let's say, is normal, right? But we have increased perfusion, lots of blood flowing over there. So it's not very efficient. When this happens, then arterioles will constrict. And here we have match, right? So we have ventilation and perfusion coupling over here. So when we have this match, when we have more perfusion, then pulmonary arterioles serving this alveoli will constrict, and this will be auto-regulated. Now here we also have mismatched. Well, here we have large ventilation, right, and very small perfusion. That's not good, right? What are we gonna do? We're gonna dilate this arteriole. So arterioles dilate. Again, we have match, ventilation and perfusion. And this will make gas exchange more, what is it? That's more efficient. That makes sense? Okay. And the last factor, so we said what affect the external respiration is partial pressure gradient. We described it, right? Ventilation-perfusion coupling and structural characteristic of respiratory membrane. That's this one. What is respiratory membrane? So respiratory membrane is actually the membrane, right, or some structure between alveoli and blood. So, and what it's made of? It's made of alveolar epithelium. It's made from endothelium, right? So here's the endothelium of the blood vessels, of the capillaries. And between them, we have basement membrane, fused basement membrane of both, right? So that's our three parts or three components of respiratory membrane. So oxygen moves through it, carbon dioxide moves through it, right? And it's very thin, about 0.5 to 1 micrometers thick, and it has large total surface area, 40 times that of your skin. And when it's thickened, right, for example, if lungs become waterlogged and edematous, so they have edema, then gas exchange became inadequate, right? So if you see, if it's going to be thick, it's going to be harder for oxygen, carbon dioxide to diffuse through. Right, so that was external respiration and factors that affects external respiration. Now internal respiration. Internal respiration is a capillary gas exchange in body tissues. And also now in internal respiration, what do we have? Oxygen need to move from blood to the tissues, and carbon dioxide need to move from tissues to the blood. And again, what is that force that make this movement happen? And this would be partial pressure of oxygen and carbon dioxide, right? So let's look over here. So we already said this over here, this is our external respiration. And here on the bottom, this is internal respiration. Now blood flowing to the tissue. Now this blood is 140, right? Partial pressure of oxygen 100, partial pressure of carbon dioxide is 40, right? That's why I told you, you need to remember these numbers. So blood is coming to the tissue. Now, what is in your tissue? In your tissue, it's actually, well, it's similar to the blood returning. You see how blood returning, you need to remember also 40, 45. So 140, 40, 45. So in a tissue, the oxygen is a little bit less than 40 and carbon dioxide is a little bit greater than 45, right? But even if we say it's 40 and 45, right? So we have 100 oxygen and we have 40 oxygen. So obviously oxygen moves from blood to the tissue. And we have 45 or even a little bit higher. And over here we have 40, right? So carbon dioxide moves in, and that's why returning blood became 40, 45, similar to your tissue. And that returns back to the heart, right? So makes sense? Okay. So that's our external and internal respiration. And now, how do we transport blood? Why do we transport blood? How we transport oxygen and carbon dioxide? And why are we talking about it? Because we're discussing this process of respiration. We talk about pulmonary ventilation. We talk about external respiration, internal respiration, right? And watch it again because I know it's a lot. And now we're talking about transport of oxygen and carbon dioxide in the blood. Okay, so I'm going back over here. So we covered a lot. So here's our transport. So transport of respiratory gases by blood. So we have what? Oxygen transport and carbon dioxide transport. Oxygen transport. Molecular oxygen is carried in the blood. 1.5% dissolved in plasma. 98.5% loosely bound to the iron of the hemoglobin in a red blood cells, right? You know, red blood cells, their major job is to transport oxygen, and they have this hemoglobin molecule, and each hemoglobin molecule has two. Hemoglobin means globin is protein, and heme is this pigment that has iron. So each hemoglobin has 4 ions and 1 molecule of oxygen, actually bounded to 1 ion, so 4 molecules per hemoglobin, right? So 1 molecule of hemoglobin carry 4 molecules of oxygen. Let me draw it very quickly, even, of course, you know, the whole deal for me to get this, but for example, if this is a molecule of hemoglobin, right, and of course there's gonna be like, that's a protein, so this is globin, right? This is what? This is this, globin, so that's globin. And then we have heme. So here's the heme group, here's the heme group, here's the heme. This is in your, I think in a lab lecture. So heme group. And inside this heme group, we have iron. Right, so here's the iron. Sorry, hopefully it makes more sense because, you know, I'm not that good at using this pen, but I'm trying my best, right? Okay, and here we have one more, right? So that's a heme. So that's a heme. So those, right? And now we have oxygen. So one oxygen is attached over here. One oxygen is attached over here to iron, right? One oxygen over here. And one oxygen attached right here. So that's what it says. It says then 1 molecule of hemoglobin, right? So this is our, this circles inside are heme. This is big circle is globin. So together it's hemoglobin. So 1 hemoglobin carries 1, 2, 3, 4 oxygen. Yeah. Well, now after that, I cannot move to the next slide. Can you believe it? That's the whole problem. So let me see why it's happened. What do I need to do this? I don't want to, I can clear all drawings. Okay, now it's gonna help. No. Nope. Still not doing anything. So again, need to stop sharing for a second. Yeah, I know. Sorry for that. And my goodness. Okay. I will figure it out how to do it. Okay, so that's the transport of oxygen. Now oxygen and hemoglobin. So when oxygen is attached to hemoglobin, we call it oxyhemoglobin. So it's a hemoglobin oxygen combination, makes sense. And when hemoglobin loses oxygen, we call it reduced hemoglobin, right? So it's abbreviated HHB, right? Hemoglobin Z has released oxygen. So here's our reduced hemoglobin, right? When oxygen is attached in the lungs, we have oxyhemoglobin, right? In the tissue, we have reduced hemoglobin. Loading and loading and unloading of oxygen is facilitated by changes in the shape of hemoglobin. So why, I just told you when oxygen is attached to hemoglobin, it's oxyhemoglobin. When hemoglobin loses oxygen, it's reduced hemoglobin. Now, why it happened? Because hemoglobin changes shape, right? Hemoglobin changes shape and it's load or unload oxygen. Now, fully over 100 saturated hemoglobin, if all of heme groups carry oxygen. So this is fully saturated hemoglobin. And it can be partially saturated hemoglobin. For example, this one, when it has more than 4, it can have 3, 2, or 1 oxygen per molecule. Then it's partially saturated. So rate of loading and unloading of oxygen is regulated by partial pressure of oxygen, temperature, blood pH, and partial pressure of carbon dioxide. So we just said that what we load your hemoglobin in the lungs, we unload hemoglobin in the tissue, but how fast your body can do it depends on partial pressure of oxygen, partial pressure of carbon dioxide, temperature, and pH of blood. Right, so over here, very interesting curve. It's called oxygen hemoglobin dissociation curve or hemoglobin saturation curve. So you can see that when we increase partial pressure of oxygen, right? So for example, you are in lungs, right? You are in lungs. So when you have more oxygen in the lungs, right, more and more hemoglobin is saturated. So more and more of hemoglobin has all these 4 molecules of oxygen, right? But when partial pressure reaches about over here 75, right, millimeters mercury, it's about 75. It shows here 80, but it actually starts earlier at 75. Now we have this curve became flat. What it means that when you partial pressure of oxygen, when it's 75, almost like 98% of hemoglobin is 100% saturated. So when partial pressure of oxygen is 75 millimeters mercury, all your hemoglobin carry as much oxygen as it can. It can really, you increase the partial pressure of oxygen. For example, you're gonna breathe like the pure oxygen, just not air, pure oxygen. It's not really, it will not really affect the saturation of hemoglobin because hemoglobin already carries 4 molecules of oxygen, and further increase, right, in the partial pressure of oxygen doesn't affect it that much. That's what it says. That's the graph. So in arterial blood, remember, partial pressure of oxygen is 100 millimeters mercury, and at this pressure, 98% of hemoglobin is saturated. So further increase in the partial pressure of oxygen, for example, breathing deeply, produces minimal increase in oxygen binding. In venous blood, partial pressure of oxygen is 40 and hemoglobin is 75% saturated. So hemoglobin is almost completely saturated at partial pressure of 70. And further increase in partial pressure produce only small increase in oxygen binding. So that means that, you know, we're pretty much good. When our pressure is 100, right? And even when pressure is 40, almost all hemoglobin carries oxygen still, right? Here, of course, less. But you have enough amount of oxygen carried by hemoglobin if you of course don't have any, you know, conditions, for example, like you have less hemoglobin, right? That's where you would suffer from a low oxygen level. You don't have enough hemoglobin or you don't have enough red blood cells. But if your circulatory system works normally, right, and your lungs works normally, then you have maximum saturation of hemoglobin. Okay. So you can see even in venous blood, right, we have 75% hemoglobin saturation. So only 20-25% of bound oxygen is unloaded during one systemic circulation. So it means that you don't unload all the oxygen into your tissue, right? You only unload 20-25%. And if oxygen levels in tissue drops, then more oxygen will dissociate. So this gives you this ability to bring more oxygen to your tissue. Because under normal condition, so enough to support your normal functions of all of your organ, you only need to unload 25% of oxygen. And this gives you opportunity when you start, you know, really working hard, when you need more and more oxygen, when your tissue need more oxygen, you have a lot of oxygen still available, right? And plus you can increase respiratory rate, cardiac output. So this gives you like a huge amount of oxygen still available for tissue when it's in need of extra oxygen. All right, so that's what just tells you that this is your normal amount of oxygen, and you unload in the resting tissue, right? And this is how much addition oxygen you can unload if you need to. So other factors influence hemoglobin saturation is increase in temperature, concentration of hydrogen ions, partial pressure of carbon dioxide. So modify the structure. Okay, so that would happen. So all these factors, they modify the structure of hemoglobin. And hemoglobin is protein, right? And when we modify structure of hemoglobin, it decreases its affinity for oxygen. And this occurs in systemic capillaries, enhance oxygen unloading, and shift the oxygen hemoglobin dissociation curve to the right. I'll show it to you. And decrease in this factor, shift curve to the left. It will be on the next slide. But the point is, when we have increase in all of these factors, that changes shape of hemoglobin. And when it changes shape of hemoglobin, oxygen leaves it, right? I don't want to be this hemoglobin that is the wrong shape, right? So it decreases the affinity of oxygen in hemoglobin, and it's easy to unload oxygen, right? So over here, you can see that here's normal body temperature, right? So when body temperature increases, right? When body temperature increases, saturation of hemoglobin is decreases, right? So more oxygen is unloaded, right? Because that's a saturation of hemoglobin. So less hemoglobin is saturated means what? Less oxygen is carrying. That means it's unloaded it, right? So when the temperature decreases, however, then saturation of hemoglobin increases over here. So we do not unload that much of oxygen. This is what it says, that shifts the oxygen hemoglobin dissociation curve to the right when we have increase. So it's shifted to the right, right? And here also increase of this concentration of hydrogen. So it's decreased, it increases acidity. So it shifts the curve to the right. So more oxygen is unloaded. Okay. Okay. So we already said that increase of hydrogen ions, but also increase in partial pressure of carbon dioxide. This all increase the release of oxygen by hemoglobin. We just looked over here. This is what it is right there. And the same at heat production. So pretty much this slide just tells you exactly what this says. It says that all these factors, when they increase, right, that actually would increase the enhance, so increase unloading of oxygen because the shape of hemoglobin changes. So that's the same stuff. Now, hypoxia. Hypoxia is inadequate oxygen delivery to tissues. And why would you deliver low amount of oxygen to your tissue? It can be of many reasons. Too few red blood cells, abnormal or too little hemoglobin, blocked circulation, metabolic poisons, pulmonary diseases, carbon monoxide, right? So that's all can cause hypoxia. Okay, so that was oxygen transport. Now carbon dioxide transport. So carbon dioxide transport in the blood in three forms. 7 to 10% dissolved in plasma, 20% bound to hemoglobin, but not to heme group, but to the globin, and forming carbaminohemoglobin. And most of the carbon dioxide, 70%, transport as bicarbonate ions. So this is HCO3 minus in plasma, right? So when carbon dioxide reacts with water, it's formed carbonic acid. Carbonic acid is not stable. It dissociates. It dissociates into hydrogen ion and bicarbonate ion, right? So most of the carbon dioxide is carried in this form by carbonate ion. So now this process can happen in plasma, but most of this happen actually in red blood cells, in a cytoplasm of red blood cells, because red blood cells, they have a special enzymes, carbonic anhydrase, that reversibly catalyze this reaction. So it's catalyzed in both ways, right? So this picture explains what's going on. So here are the tissue cells. So your tissue cells, they produce carbon dioxide as metabolic byproduct, right? So carbon dioxide is produced and now it moves from tissue to the blood. Now in the blood, here's your plasma, here's your red blood cells. So some carbon dioxide dissolved in the plasma, right? Some carbon dioxide converted into bicarbonate ions in the plasma, but small amount. So most of the carbon dioxide actually enters red blood cell, right? And you can see what happened. So some of it, what is this percentage? 20%, right? 20% binds to hemoglobin and form carbaminohemoglobin, right? And most of it, 70%, is converted into bicarbonate. So you see it's converted here into bicarbonate, but most of carbon dioxide converted into bicarbonate inside red blood cells. And then it's actually leave RBCs, right? And it's moved to the plasma. So bicarbonate ions move to the plasma, chloride ions moves in. It's called chloride shift because we have this transport protein, right? It's a antiport, chloride in, bicarbonate out, right? And oxygen released from hemoglobin, right, to the tissues, and some that was dissolved in the plasma, small amount also, right, moved to the tissue. Now, this is what happened in the alveoli. So reverse, oxygen moves inside red blood cells, most of it, right? Some dissolved in the plasma, and carbon dioxide now, right, moves to the alveoli. Here we have very slow conversion of bicarbonate into carbon dioxide, but most of it, look, here moves back to the red blood cells. Chloride moves back out. Again, chloride shift happens. And here we have this enzyme, carbonic anhydrase, that converts this bicarbonate back to carbon dioxide and then to the alveoli, right? So the amount of carbon dioxide transported is affected actually by partial pressure of oxygen. The low partial pressure of oxygen and hemoglobin saturation with oxygen, more carbon dioxide can be carried in the blood. So look, let's say if we have a partial pressure of oxygen 40 millimeters mercury here, this is how much carbon dioxide is carried. If we have higher partial pressure or concentration of oxygen in blood, then less carbon dioxide is carried. We have lower partial pressure of oxygen, more carbon dioxide carried. So we said that we carry, where is it? We carry carbon dioxide in the blood, but more oxygen you have in your blood, less carbon dioxide you carry. Less oxygen you have, more carbon dioxide will be carried. That makes sense? Yeah, that's what it says. And it's called Haldane effect. That amount of carbon dioxide transported is affected by partial pressure of oxygen. This is our Haldane effect. Okay, so that's what pretty much we just said. Okay. Another thing over here, it says that influence of carbon dioxide on blood pH. You guys did cover it in 50A. We know that carbon dioxide over here, let me go back. Carbon dioxide reacts with water, forming carbonic acid, and then it's dissociated into hydrogen ion and bicarbonate. And this actually is called, this is, and it's called the buffer system of your blood, right? So this buffer system help your blood to keep a constant pH. right? So if concentration of hydrogen ions in the blood rises, right? So when concentration of hydrogen ion rises, blood became more acidic. Then these excess hydrogen ions are removed by combining with bicarbonate. If concentration drops, then carbonic acid dissociate and releasing this hydrogen ion. So this is how your blood regulates its pH through this buffer, a carbonic acid bicarbonate buffer system. Changes in respiratory rate can also affect blood pH. So this carbonic acid bicarbonate buffer system, right, and affects the keeps your pH constant, right, because carbon dioxide will make your blood acidic, right? Carbon dioxide will make your blood acidic. That's why you have this buffer system to keep pH constant. Now, what else can make your blood acidic? Changes in respiratory rate. For example, shallow breathing allows carbon dioxide accumulation in the blood, and this causing pH drops, so blood became acidic. Changes in ventilation can be used to adjust pH when it's distributed by metabolic factors, right? So you start breathing more intensively when pH of your blood drops. Rising carbon dioxide level is the most powerful respiratory stimulant. So when the blood concentration of carbon dioxide increases, that stimulate your respiratory system, right? So you increase your breathing rate, right, and the work of the lungs. Partial pressure of oxygen affects your breathing only indirectly, right? So the main stimulant for your ventilation is level of carbon dioxide. Okay, and very quickly, because I already, it's a long lecture, I knew it, 70 slides. So some homeostatic imbalances. So chronic obstructive pulmonary diseases, or COPD. And two examples are bronchitis and emphysema. It's a reversible decrease in the ability to force air out of the lungs. So other common features, history of smoking, dyspnea or labor breathing, coughing, frequent pulmonary infections, and most victims develop respiratory failure accompanied by respiratory acidosis. So here you can see that two major chronic obstructive respiratory diseases are chronic bronchitis and emphysema, and what both of them do, they trap the air. Patients have trouble to exhale and lungs became larger. So you trap air inside the lungs. Asthma is autoimmune disease or some immune disease. So it's inflammation and immune response. Let's say it this way, right? So characterized by coughing, dyspnea, sneezing, chest tightness. Active inflammation of the airways precedes bronchospasm. So asthma starts with inflammation, and then your immune system responds by releasing chemicals such interleukins, immunoglobulin E, right? And it causes bronchospasm. Airway thickens with inflammatory exudate magnifies the effect of bronchospasm as well. So asthma starts as inflammation, and then your immune system responds to this inflammation, and this is cause the constriction of airways and bronchospasm. Tuberculosis is an infection disease caused by bacterium, Mycobacterium tuberculosis, and symptoms include fever, night sweats, weight loss, racking cough, spitting of blood, and treatment with antibiotics. And the last one is lung cancer. So a leading cause of cancer deaths in North America. So most people here die from out of all the cancers, they die from lung cancer. 90% cases are a result of smoking. And there are three major types: squamous cells carcinoma. This is where the epithelium, bronchial epithelium, becomes cancerous. Adenocarcinoma, this is the most common, 40% of all the cases. And adeno means gland, so it's originate in the peripheral lung area, but it's a cancer of the secreting or glandular cells, like for example the ones that secrete mucus. So that adenocarcinoma. Squamous cell carcinoma, that's epithelium, an epithelium, bronchial epithelium is simple squamous, that's why it's called. And small cell carcinoma, about 20%, it's lymphocyte-like cells became cancers. And it's originate in the primary bronchi and subsequently metastasized. So that's it. So that's it for this chapter. Sorry, it took me a little bit longer than I planned, but I hope it was helpful, and thank you for watching.